Welcome friends to yet another session in orthopedics. Today we'll be discussing the recall questions from the recently concluded FMGE 2023 question paper. Okay, so we'll be discussing all the orthopedics questions from that question paper. And as you all would have realized after the exam this year was quite difficult when compared to the previous 2 years. Anyway, if you look at orthopedics per se, most of the questions were on rather expected lines. There were one or two difficult questions, but most of them were on expected lines. Anyway, we will discuss these questions one by one. I hope that all of you would have got everything correct. Alright, let's move on. Now we'll start with our first question. A 16-year-old male presents to the OPD complaining of pain in his left leg. X-ray is shown below. What is the diagnosis? Is it osteoid osteoma, GCT, osteosarcoma, or unicameral bone cyst? So let's discuss this X-ray. So what is the diagnosis here? If you look at this X-ray, you can clearly see that there is a lesion, and the lesion is in the diaphysis, isn't it? So this much area is the epiphysis, this is the metaphysis, and the lesion is clearly in the diaphysis. And if you look closely, you will see that there is a small radiolucent area in the center. There is a radiolucent area here, and around the radiolucent area there is intense whitish color or intense sclerosis. Okay, and what is this? A central lytic lesion in the diaphysis surrounded by intense sclerosis. This is a classical description of osteoid osteoma. So that is our first answer here, osteoid osteoma. It can never be GCT. Why? The age group of GCT is between 20 to 40 years. Here the patient is 16 years of age, isn't it? So it is unlikely to be GCT. Further, GCT always involves the epiphysis, and never the diaphysis. What about osteosarcoma? Osteosarcoma involves the metaphysis, and it is usually associated with the classical periosteal reactions such as sunburst appearance or your Codman's triangle. Any of these would definitely be seen if there is osteosarcoma. Alright, so it is not osteosarcoma. It can also not be unicameral bone cyst, because UBC is also seen in the metaphysis as a cyst like this, and one feature of UBC is that it does not produce sclerosis. Sclerosis will be absent in UBC. So there is only one answer here, osteoid osteoma. Alright, let's look at the second question. A 16-year-old patient complains of painless mass above his right knee, which is gradually growing in size. X-ray reveals the following. What is the diagnosis? Is it osteochondroma, osteosarcoma, multiple myeloma, or Ewing sarcoma? I think this is a straightforward question, and I'm sure that most of you would have got this answer correct, isn't it? So if you look at this X-ray, you can clearly see that this is a pedunculated lesion. There is a pedicle and there is a bulbous end like this. And if you look closely, you will see that the cortex of the parent bone is continuing with the cortex of the tumor. Similarly, the medullary canal of the parent bone is continuing into the tumor. Again, if you look at the direction of growth, this is your knee joint. And what is the direction of growth? It is away from the knee joint. All these are classical findings you see in osteochondroma. So that is our answer here. It cannot be osteosarcoma because, as we discussed, there would have been characteristic periosteal reactions. That is absent here. Multiple myeloma never occurs at 16 years of age. It is seen after 50 years of age, and the classical features would be lytic lesions and not a growth like this. And Ewing sarcoma is a diaphyseal lesion, and it will produce the classical onion peel appearance. Onion peel periosteal reaction. None of these are present. So our answer here is osteochondroma. Alright. Now the third question. A patient presented with skin lesions of body as shown in the image. On evaluation, he has pain and swelling in the distal interphalangeal joint. What is the diagnosis? Is it reactive arthritis, osteoarthritis, rheumatoid arthritis, or psoriatic arthritis? And an image as given here, you can see that there are lesions on the skin, isn't it? Further, there is arthritis involving the distal interphalangeal joint. So can it be a reactive arthritis, Always remember that reactive arthritis is preceded by an infection. There will always be a history of infection, and infection after about 1 or 2 weeks would be followed by a classical triad. What is the triad of reactive arthritis? You have arthritis, obviously. There will be arthritis. Along with that, there will be urethritis, and along with that, there will be conjunctivitis, or sometimes uveitis in the eye. Okay, the classical triad of arthritis, urethritis, and conjunctivitis or uveitis in the eye. So this is your reactive arthritis. That is not our answer here. And what about osteoarthritis? Osteoarthritis can definitely affect the distal interphalangeal joint, but will it produce any skin lesions? It will never produce a skin lesion. Always remember that osteoarthritis is a non-inflammatory degenerative condition. Alright, it is non-inflammatory. It will not produce any extra-articular manifestations. The only manifestation will be loss of cartilage and arthritis in the joints. Okay, so that is also not our answer. Now, what about rheumatoid arthritis? Rheumatoid arthritis can cause skin lesions, but it is characteristically subcutaneous nodules and not superficial lesions, as you see in the picture here. So, one important point again you have to note here is that distal interphalangeal joint is classically spared. DIP is spared in rheumatoid arthritis. This is a very important concept that you need to know. DIP, if it is involved, it can never be rheumatoid arthritis. Always remember this, okay? And the last option is psoriatic arthritis, and that is our answer here, which classically involves the distal interphalangeal joint and produces skin lesions like this. This is our answer here. Moving on to the fourth question. A 50-year-old male presented with complaints of sudden onset weakness and pain in the arm. On examination, the following feature was present. What is the diagnosis? Is it biceps tear, triceps tear, brachioradialis tear, or brachialis tear? What is the answer here? You can see that there is a small bump here, isn't it, in the distal part of the anterior arm. What is this? This is the classical Popeye sign. And this occurs because of rupture of the long head of biceps tendon. Long head of biceps tendon ruptures, produces this sign. Okay, how does this happen? We all know that biceps has two ends, isn't it? One is your short head, which is attached to the tip of the coracoid process here. Then you have a long head which passes between the greater tuberosity and the lesser tuberosity and gets attached onto the top of the glenoid process. Okay, so you have the short head and the long head. Always remember that the long head of biceps is intra-articular. It is inside the shoulder joint. So because of various causes, there could be degeneration and inflammation of this tendon. Okay, long head of biceps can undergo tendinosis and tendinitis, and this will make this tendon weak. Okay, what happens when a patient with already degenerated tendon tries to do a hard work, when he tries to lift a heavy weight, if he tries to climb up a ladder, what will happen? Suddenly, without warning, this already weakened tendon will rupture, and all the fibers here, all the muscle fibers, here the tendon is ruptured, all muscle fibers will retract distally and will bunch up here, okay, like this, and this will present to you like a mass like this in the distal aspect of the anterior arm. This is your classical Popeye sign. This occurs because of the tear of the long head of biceps tendon. Here, long head of biceps tendon option is not available. Biceps tear is also correct. Okay, so that is our answer here. Next question. A 6-year-old child had a history of fracture near the left elbow, for which he had undergone native treatment. He now presents with a deformity as shown in the image. What is the diagnosis? Is it cubitis valgus, gunstock deformity, or dinner fork deformity? Let's look at the picture again. So we can see that there is definitely a deformity at the elbow. So if there is a deformity at the elbow, you use the term cubitus. Okay, cubitus means elbow. If it is genu, genu means the knee, and coxa means the hip. So whenever there is a deformity at the elbow, you call it as cubitus valgus or cubitus varus. Next question is it valgus or varus? So whenever a question regarding deformity comes to you, always think about three things. One is you have to draw a midline like this. Okay, you draw a midline. You can just imagine a midline. That is enough. Then second is you mark the point where the deformity is. Here it is the elbow. Then you look at the distal part of that point. Okay. So what is the part distal to the elbow? It is your forearm. Okay. Always whenever we are describing a deformity, we take into account the distal part of the deformity. Distal, never proximal. You don't have to worry about the position of the arm at all here. You have to worry about the position of the forearm. And if the forearm is directed towards the midline, you call it cubitus varus. And if the distal part is or the forearm is facing away from the midline, you call it valgus. Here what is happening? Definitely the forearm is deviated away from the midline. This is your classical valgus. This concept holds true even for the knee. If the leg is deviated outwards away from the midline, you call it genu valgum. If it is curved inwards or if it is directed inwards, you call it genu varum. Same concept everywhere in the body for varus and valgus. Here it is affecting the elbow, so the answer is cubitus valgus. So that is our answer here, cubitus valgus. Moving on to the next question. A 5-year-old child presented to the hospital with complaints of limited abduction of shoulder. Identify the deformity responsible for his condition. Is it Klippel-Feil syndrome, Sprengel's deformity, congenital torticollis, or muscular spasm? This is actually a previous year question, isn't it? Has been repeated twice now. So can you tell me what is the problem here? You can see that here the scapula is at a normal level. What has happened here? The scapula is high riding, isn't it? It is not at its normal level. It is placed at a higher level. Why does this happen? This happens because of failure of descent of scapula. The normal descent of the scapula during embryogenesis does not take place properly, resulting in a high riding scapula. This is what is called as Sprengel's deformity. Sprengel's deformity. I'll show you how this occurs. So this is a very rough diagram of the embryo. This is the cervical spine here. And in the embryo, the scapula actually develops close to the cervical spine like this. And over the period of development, the scapula will slowly descend down and come to its normal position. This is what happens normally. But sometimes there is an abnormal connection between the scapula and the cervical spine. This is what is known as the omovertebral bone. Omovertebral bone, very important. And because of this omovertebral bone, the normal descent of the scapula does not take place. So on one side, the scapula is at the normal level. On the other side, the scapula is at a high level. This is your classical Sprengel's deformity. Alright, moving on to the next question. A patient presented with the following X-ray and clinical finding. Injury to which of the following nerves result in this presentation? Is it ulnar nerve, radial nerve, median nerve, and axillary nerve? This is a straightforward question. I hope that most of you would have got this right, isn't it? What is the deformity shown here? This is your classical wrist drop, isn't it? The wrist is dropped down, or it is in palmar flexion. This is the classical wrist drop. Wrist drop occurs because of the paralysis of the extensors of the wrist joint. The extensors of the wrist joints are paralyzed, and the nerve supplying all the wrist extensors are the radial nerve. So radial nerve is what results in wrist drop. And what is this X-ray of? This is an X-ray showing the fracture of the distal third of the humerus. And the radial nerve actually passes like this. It comes downwards like this, winds around the spiral groove, and comes anteriorly by piercing the intermuscular septum. And the point where the nerve pierces the intermuscular septum, the nerve is tethered there. It is fixed there. It cannot move a great deal. So when there is a fracture adjacent to it, the fracture fragment can go and poke at the radial nerve, causing paralysis. And what do you call this kind of fracture? A fracture of the distal third of the humerus with an associated radial nerve injury? It is your classical, yes, it is your Holstein-Lewis fracture. Holstein-Lewis fracture. Okay. Anyway, our answer here is radial nerve. Alright. Next question. What is the test done to identify flexion deformity at hip? Is it anterior drawer test, telescopy test, Thomas test, or Lachman test? What is the answer here? Is it anterior drawer test? No, anterior drawer test is a test for ACL injury. ACL is your anterior cruciate ligament injury. In order to test those kinds of injuries, we do an anterior drawer test. Similarly, Lachman test is also for an ACL injury. Okay, where do you do a telescopy test? It is for identification of an unstable hip. Okay, unstable hips will present with a positive telescoping test. All right, our answer here is Thomas test or Thomas well leg flexion test. What is this test? I'll explain this to you. A little bit of conceptual knowledge is required to understand Thomas test. I'll explain it to you now. Okay. So what is this flexion deformity? So whenever a joint is flexed like this and the patient is unable to extend beyond it, then you call it a flexion deformity. See here, I have just shown that my elbow has a flexion deformity like this and I cannot extend it. Okay. So why do you need a clinical test? I can just look at my elbow and say that, okay, my elbow is flexed, so obviously there is a flexion deformity. If I have a flexion deformity of the finger like this, you can just look at my finger and say that Dr. Rohith has a flexion deformity of the finger, isn't it? What is so special about the hip? Why do we need a test for identifying a flexion deformity? The problem here is that flexion deformity of the hip can be masked. Okay, masked by the patient. How is this possible? I'll show you. So if you look at this picture, this patient has a flexion deformity at the hip, isn't it? The hip is flexed. So this patient has a flexion deformity at the hip. Imagine this patient lying down on a cot. When he lies down, the thigh is up, isn't it? The thigh is up. So the patient cannot sleep properly because the thigh is up and it is going to cause pain. So what will he do? He will try and bring the thigh down and try and touch the thigh on the cot like this. And how can you do this? You can do this by elevating the pelvis. Okay. So if you look here, the flexion deformity is similar on both the pictures, isn't it? Here the thigh is up, here the pelvis is up. So in order to bring the thighs parallel to each other, in order to bring the thigh onto the cot, he will try and elevate the pelvis. And when the pelvis is lifted up, the spine will arch backwards like this. This is what is known as a lordosis of the spine. Posterior arching of the spine is lordosis. And this is what we call as a compensatory lordosis of the spine. So a fixed flexion deformity of the hip can be masked by a compensatory lordosis. Okay. So just by looking at the hip, we will not be able to say that the patient has a flexion deformity or not. So in order to identify a flexion deformity, we have to first obliterate the lordosis. We will have to completely eliminate this compensatory lordosis to identify the flexion deformity. And how can you do that? It is very easy. You just hyperflex the normal side. You hyperflex the normal side. When you do that, the pelvis is brought down to its normal position and the thigh will move up, clearly unmasking the flexion deformity here. So that is what you do in Thomas test. We are doing a hyperflexion of the well leg. That is why it is called as a Thomas well leg flexion test for unmasking the flexion deformity of a hip joint. Okay. Next question. A patient presented to the OPD with difficulty in strugging of the shoulder. Which of the following nerve is injured in this case? Long thoracic nerve, suprascapular nerve, spinal accessory nerve, or axillary nerve? This is a straightforward question, isn't it? Which is the muscle that causes shrugging of the shoulder? Shrugging of the shoulder is brought about by your trapezius, isn't it? Trapezius. And trapezius is supplied by your spinal accessory nerve. So that is our answer here. Alright. Next question. A mother with history of vaginal delivery 2 days ago complains of numbness in the lateral aspect of thigh. Which nerve is likely to have been damaged? Is it the femoral nerve, lateral cutaneous nerve of thigh, obturator nerve, or sciatic nerve? So what is the answer here? Which is the nerve that supplies the lateral aspect of thigh? It is your lateral cutaneous nerve of thigh, isn't it? It is also known by another name. What is the other name for it? It is the lateral femoral cutaneous nerve. Okay. So what happens is that during vaginal delivery, sometimes we have to do the Mac-Roberts maneuver where we hyperflex the hip to aid in the normal vaginal delivery. Okay, this Mac-Roberts maneuver can cause injury to the lateral femoral cutaneous nerve. Why? Because the lateral femoral cutaneous nerve or the lateral cutaneous nerve of thigh, it arises from the lumbar plexus. It descends downwards, it passes behind the inguinal ligament before it comes down and supplies the anterolateral and the lateral aspect of the thigh. So at this area where it passes under the inguinal ligament, there is a high chance that when the patient's hips are hyperflexed, this nerve can get kinked and can cause damage. And when this damage occurs, there will be sensory paresthesias and numbness over the anterolateral and the lateral aspect of thigh. This is what happens here. Okay. And what do you call the compression neuropathy of the lateral femoral cutaneous nerve? It is known as meralgia. Meralgia paresthetica. Okay. Very, very important. All right. So these were the 10 questions from orthopedics. I hope you have got most of them correct. Don't worry if you have made few mistakes. Don't worry at all. Be calm. The results will be out soon. And I hope and pray that all of you would pass with flying colors. All right. Thank you.